We're back. The Strength and Knowledge podcast is back. My name is John Allan, and today's overarching topic is all things lumbar bone stress injuries, with the emphasis on shocking prevalence and severity, KPIs for introducing plyometrics and impact, and what to do when things go south in phase 3 of rehab. And who better to dive into this topic than two leaders in the field of lumbar bone stress injury rehab, Doctors Joey and Rayce from Rehab Renaissance. For the viewers who are unfamiliar with the great work you all do, Joey, why don't you introduce yourself first, and then Rayce can follow.
Yeah, thanks for having me, John. A little bit about me, Joey Scambia. I'm board certified specialist in sports physical therapy, own my own practice up in Oceanport, New Jersey, and I had a history of lumbar bone stress injury myself. So happy to dive into this and get into the weeds a little bit in terms of severity, prevalence, and then KPIs.
Well, then, thanks for having us again, John. My name is Rayce, PT out here in the Pacific Northwest. Currently work at Rope, which is a performance therapy clinic out here, and work with a large number of baseball athletes, and so definitely see a ton of spondys out here.
Perfect. Yeah. I know you guys made a post recently about like which sport you see a lot of it, and like soccer was one of the top ones. So let's dive into that right away. Just kind of talking about like you see a sport and you see low back injury. Like talk about just kind of like your thought process between like how you're ranking bony stress injuries in like kind of your tier list, and then where you go from there.
I'll kick this one off. Basically, kind of like we touched on before in the pre-recording. If I see anybody who's, within the age of like, say, 12 through 17, 18 years old, and I see low back pain, like I'm already thinking this is a spondy, and I'm almost going to start approaching it as a spondy until I'm confident that it's not a spondy. There is some newer literature out there that basically shows it's pretty much a coin flip chance that if there's an adolescent athlete that has pain that shows up to a clinic, like odds are they're going to have a spondy, like coin flip chance. So we're already dealing with a 50%, probability that we're going to be dealing with a bone stress injury. So that's where, a thorough subjective in terms of, when this started, where symptoms are, what their nutrition has been, has there been any sort of, weight loss or potential relative energy deficiency? What has training looked like? Has there been a ramp up in volume? Has there been a recent growth spurt? So there's many, many things like subjectively I'd want to dive into to kind of make sure that I'm either confident that this is a spondy, and if so, like, hey, we should probably get this image sooner rather than later because the results of a better prognosis are much better if we get imaging early versus if these are not pointing me down the spondy route. Is it, disc? Is it, lumbar strain? Like, what other potential differential is it if it's not pointing me down that spondy route?
Hmm. And honestly, the research, depending on what study you look at, I don't think we have a great grasp on are there maybe specific sports that are more involved because like you wouldn't think basketball would be a high prevalence in terms of spondies, but I came across an article maybe a couple weeks old, and I think of the population that they were looking at, basketball is actually the highest in terms of their population, and I think lacrosse was second. Diving, cricket, weightlifting, etc. It seems like regardless of maybe what sport you play, if you kind of fall into that adolescent range, if you have back pain, it seems like I'm probably thinking more spondy related until proven otherwise. And then kind of going off a similar point into what Joy mentioned in terms of, low energy availability and getting more into some of the REDS factors. We have some research to suggest that the more proximal the site is for the bone stress injury, typically we're thinking there's going to be more REDS factors involved, whether it's low bone mineral density, whether it's low energy availability, if they're female, maybe some sort of menstrual dysfunction there. And so understand that, if we're having someone with a spondy, it's proximal, more trabecular bones. So I'm already having some other, like some other antennas raised in terms of other factors being involved there. And then when we start to even look more in terms of specific sports, when we think of our figure skaters, probably even diving, gymnastics, some of those sports that have probably a more aesthetic component to it, like there's probably more likely of a chance that there's going to be some low energy availability component to that versus just being a pure workload issue.
Right, yeah, like the complexity of low back pain is already a lot of confusing for the average clinician, and then you add the nuances of being a high school, middle schooler. You got all like the things that you touched on, like reds, growth spurts, volume overloads, and then the aesthetic components. Like it's a perfect storm for bony stress injuries and spondies like that. So yeah, all that stuff is great and important, and we're gonna kind of transition right into like kind of almost skipping stage one into the end stage of two and talk about like intro to plyometrics. what movement competencies are you guys looking for in certain planes and patterns that'll provide you confidence that this athlete will do well getting into some plyometric and impact type activities?
Yeah, I think we kind of make two separate distinctions of like um pattern, stance, plane, and then like load, velocity, and duration, right? So obviously we want them to be comfortable moving at, a relatively slow to moderate load first, relatively low to moderate like external load, um, and like slow to moderate in kind of all those variables. And then obviously we want them comfortable in, supine, side lying, tall and half kneeling, standing, your asymmetrical or unilateral stances. Basically just show us that you can tolerate either like pretty high intent isometric loading in any of those positions or planes, or high amounts or moderate amounts of isotonic loading in any of those planes, because obviously sport is very chaotic with ground reaction forces. They can be up to 17 times body weight. So you got to be able to obviously load it slow through a moderate amount of load first. And then obviously that would kind of tell the clinician, okay, this person has a good like bandwidth in terms of load tolerance here. We can probably start to progress to some of our ballistics. But just because we progress to some of our ballistics doesn't mean we start like, all the way at the end stage of like high impulse, high range of motion tasks. Like we can definitely continue still building out, our isotonic menu at the trunk, but then start some very low intensity, low rotational demanding intro to ballistics, if you will, and then continue to scale that over time. I'll let Rayce expand upon kind of the quadrants that we've kind of put into play here.
Yeah, so we have a plyometric framework that's, I would say, similar to what Matt McInnes Watson has in terms of his kind of plyometric framework. We use some different terminology, but in the grand scheme of things, we have low momentum and high momentum on the y-axis, just a relative scale in terms of intensity. If we're doing a true like lower extremity plyometric, what is our jump height or fall height, which is going to dictate the velocity that we hit the floor with. Then on the x-axis, we have short coupled going to long coupled, and essentially that's just the interaction between our spatial and temporal characteristics. So with our yielding phase, how much deformation or excursion are we going through, and what's our ground contact time? So short coupled are going to be, relatively less joint excursion. And if we're thinking more of our traditional lower extremity plyos, probably thinking our ground contact times are less than 0.25 seconds there. And then as we move over to long coupled, now we're going to be going through larger joint excursion and then going through longer ground contact times, typically thinking, more so than that 0.25 seconds. We can then start to layer in how bone load is then affected by our plyometric, quadrant system there. So what we know about bone loading, some of this stems from some information that Richard Willie has posted on his Instagram. So when we look at especially our tibial and femoral loading, what's going to constitute the majority of bone load is actual the muscle force via muscular contraction. So as we're getting into longer lever links and creating longer external moment arms, that's going to necessitate the muscles creating more force to overcome that position, which is then going to result in more bone loading. So if I'm, let's say, dropping off an 18-inch box and having, an individual land, the stiffer landing, although it's going to create higher ground reaction forces just because we're going to have probably shorter time to stabilization there, it's actually going to have less bone loading because we're not going through as much joint excursion, so we're not creating the same external moment arms. So when we have our, y-axis in terms of intensity and x-axis going from left to right, being short coupled to long coupled, the short coupled on the bottom left is going to be tier 1 because it's going to be our low intensity and it's going to be our quote unquote stiffer plyos, which we're not getting into as much joint excursion. So that's going to be level 1 for bone loading. Then we move over to same thing, lower intensity, but now we're on the right hand side. So now we're long coupled. So now we're creating larger external moments. So now we're going to increase the bone loading a little bit more. As we start to scale upward in terms of intensity, we go back to the top left. So now we're a little bit higher intensity, but still short coupled. And then we go to the right-hand side, high intensity, and then long coupled there. So that's kind of the 4-tier system in terms of the bone loading, integrating that into our plyometric framework and quadrant system.
Perfect. Yeah, I definitely earlier on, I feel like I was thinking like longer coupled, like the muscles are doing all the work, but then you make a great point of like, hey, that's actually causing the bones to have to do a lot more stabilization and things like that to stack properly and all that good stuff. So I feel like that's a great point that people aren't like, oh, like longer coupled, let's really hammer the muscles. Let's hammer those abdomen, lumbar, paraspinals, things like that. But in reality, like that's putting a lot more force and a lot more like you said, the force in through the lumbar spine. So I appreciate you making that clarification, and that definitely makes sense. It's easy to follow as well. So, where are we like thinking of like anti-rotation stuff? Because I know rotation can be, from my experience, very symptomatic and just general like adolescent low back pain. Like where are we finding like anti-rotation, anti-extension type exercises in like the earlier or later phase twos?
I definitely think they're valuable. I think it all comes down to, are we exposing our athlete through a variety of motions, through a variety of loads, through a variety of contraction types? So like obviously your anti-extension, anti-rotation are one piece of the pie, right? You obviously need to be able to resist force, but also a ton of what we do in sport relies on a ton of force production. Like the amount of, torsional forces and shearing forces that go through the spine, like they can get pretty high in sport, and we need to actually prepare the body to handle those. So those are definitely some things that we're definitely doing in late stage in terms of being able to resist a lot of force in those planes. But on the other side of the coin, if we're not necessarily getting our patients out of quote unquote neutral spine through a lot of range of motion, whether it's under higher loads or higher speeds or higher intensities, we're kind of not setting them up for success because they haven't been exposed to those things. And I know Rayce saw a study not too long ago. If somebody was braced, their neutral strength was fairly similar, but when they tested strength outside of neutral with the braced population versus the non-braced, the braced population did a lot poorer in terms of the ability to express strength in those outer ranges. So that just goes back to the importance that if somebody is braced, or if somebody has to, if we put more parameters on maintaining what we would call like a relative neutral position, we're going to have to eventually expose them to those end ranges. Otherwise, they're probably going to have decrements across the board in those positions. And if they have decrements, we probably didn't do a good enough job of preparing them for their sporting demand.
And one thing we'll definitely do as we're kind of going through our progression with our individuals is, um, I feel like a lot of times when we think of our payloft press, front planks, those exercises, we typically just think about only doing them in a neutral position, but you can very easily take those and implement those in other positions. So we'll just take the payloft press, for example. I can very easily scale that to, let's say, they can tolerate 45 degrees of rotation, moderate effort, overcoming ISO. Sweet, we can start to slowly, gradually work them into more provocative positions, potentially other positions they haven't built strength and tolerance in. And eventually we can hopefully get to like an end range rotational, maybe in terms of overall trunk rotation, or close to that 90 degrees there. And we can very easily build some tolerance in those positions. Very static, a lot easier to build more competency in that position versus having them try to access it from a more dynamic standpoint. Not to say that we won't eventually get into some of those positions dynamically and have them actually move in and out of those, but I think that's an often a piece that's missed in terms of the rehab process is only doing our, anti-based movements in just neutral positions.
Yeah, and I also find myself a lot of times getting like bit on the back end about like not like minimal effective dose. I feel like I'm like, all right, this is a typical young athlete. Like they can kind of probably respond to two or three sets of, say, just depth drops, power press, whatever it may be. And then I'm like, and they're like, that first set was fine. The second set absolutely put me up to like a 6 out of 10 pain. I'm just like just taking it, scaling back, finding a volume that is like a good entry point, kind of paired with that like short coupled low intensity plyometric. I feel like it's something that I've kind of learned through experience of just like, hey, let's not rush this injury. This is not an injury that you rush, that you try to like no pain, no gain type thing. This is something that we got to take very seriously. Let the bones heal, let the muscles heal if it's truly muscular, and then go from there. Do you guys have
Yeah,
anything on dosage
yeah.
wise that
I
you
think
found that's been beneficial?
you bring up a good point there in that this is very serious, and it's also something that's super specific. I know we've had one of our mentees who I guess picked up a spondy who had seen somebody else, and like we're going through series of prone press ups and we're wondering why like they weren't getting better. So like the big delineation is that this is not your non-specific low back pain. It's very specific. There's a specific structural, pathology that's taking place. So we have to be a lot more strategic with one, how we're loading somebody in the positions that we're loading them in, and two, the acceptable pain parameters that we set with these particular patients. Because, lumbar strain or like disc, like I don't care about pushing into pain. That's totally fine. Like I would almost encourage them pushing into a very mild amount of discomfort versus with your spondys, like we can't be pushing into any, otherwise That's going to have chemical irritation in the bone. It's going to affect our ability to, progress. They're going to kind of stay in this plateaued stage for forever, until we give that, those symptoms some time to chill out so that bone can remodel, can heal itself, versus if we're just having them, like you said, push through that 6 out of 10 pain. That's not going to be helpful in this specific scenario because it is a specific pathology.
And I will say, I think you bring up another good point, John, in terms of both seriousness and duration. So there are studies that have shown with a complete stress fracture, it may take up to 412 days to actually get back to sports. So we're looking at over a full year of it taking from an individual being out from sport to getting back to sport. And I think most people just think, oh, it's going to be 8 to 12 weeks to be back playing sport. So understand the time loss injury or the potential for time loss is very, very significant. And then we start talking about when we actually have a lesion, at least a unilateral lesion, how that then alters the stress across the rest of the vertebra in terms of when we're actually going through movement. So we're already seeing increased stress on the contralateral side in terms of the pars, arch, that vertebral arch, all that area there. So we're already setting ourselves up for increased risk contralateral lesion. If we have a lesion now, that's bilaterally. Now we're at like a 75% chance that we end up going on to develop a spondylolisthesis, which not to say that's the end all be all, but there's a chance that this may now require some form of surgical intervention, which then has its whole host of complications depending on what surgical repair technique that we use. And so, yeah, I think understand the severity of the injury is super important in terms of, relaying information to the patient, how we end up going about, structuring our pain parameters. Because like Joey mentioned, we've seen plenty of people who they've been diagnosed or have been treated like they have this nonspecific low back pain. And it just takes so much longer to get them back because they've been poking into pain for, 2, 3 months and haven't gotten better.
Yeah, I feel like education goes a long way with this diagnosis and patient population. I feel like they come in a lot of times with a history of like 6 months of this back pain. They've done nothing for it. They've maybe iced it, maybe sat out of a practice or two, but definitely not sitting out of a game or anything like that. That would just be crazy ridiculous. But I feel like the expectations when they come in, and even from the parents as well, that they're going to be back on the field in 2 weeks. And then, like we were talking about earlier, it's just like educating them on the severity and how serious this injury really is. And this also kind of transitions nicely into like when they are in that phase 3, like you've tested them out of phase 2, they're confidently in phase 3, but they're just not tolerating it well, and they're not tolerating impact well or extension or rotation, whatever it may be in that plyometric phase. Like, what are your guys' kind of thought processes on how you deal with that? Do you have any like tips or tricks for the audience to kind of deal with it if they are experiencing a patient like this? And I just would love to hear your thoughts on how you kind of navigate this setback in the rehab.
I think a lot of it's going to depend on their training history and like what their perception of like effort versus pain is, because I've dealt with tons of kids who like say something's painful but can't delineate like familiar pain versus, I just worked at like a relatively high RPE and have that, muscle burn. So making sure you're actually delineating with your patient, is this familiar in terms of this brings you to PT or is it different? That's huge, I think, with the adolescent population, just getting those parameters in place because that can help dictate kind of where you go. And then the constraints you utilize can help decrease the overall, intensity of exercises. So like your supine or tall kneeling variations is going to be very hard to, gain a lot of leverage to push into the ground to generate force. So those would be super simple position swaps where you can keep the exercise like fairly similar, but that can just decrease the overall intensity. So they're doing the same thing essentially, just in a lower loaded position, which might help in terms of like improving their symptoms. So, let's say like a split stance overcoming isometric, like paddle off into the wall is painful, but like a supine or tall kneeling variation, they're still pushing at a pretty high intent, but because they don't have a lot of leverage with their feet pushing into the ground, like that could, decrease their symptoms to a point where they're doing it, but it's much more manageable and within the loading parameters that we want. So those would kind of be two things: delineate pain versus effort, and then, changing positions or adding constraints that will automatically decrease the overall amount of force output that they can display.
And then I'd say kind of looking more like big pictures, what is their overall workload? Because I think at times we're too quick to place the re-aggravation of symptoms based on what we're doing clinically, which it could be something they're doing outside of PT. Like let's say they're a baseball player and maybe we've gave them some sort of instructions in terms of slowly integrating back into maybe taking, let's say, 30 swings a day, and you're only going to swing twice a week, but we're going to get 3 days of rest in between those bouts or exposures. And let's say they end up hitting 4 or 5 times throughout the week and they're taking 50 swings, but they don't disclose that information to you. So I think making sure we have a full grasp of what they're doing outside of PT, because that's going to dictate overall, how sensitive that bone is to loading, especially too if they're having these sudden spikes in workload there. And then I actually want to go back to a point you brought up in terms of kind of around the aspect of pain. And I almost feel like in certain sports, baseball, probably lacrosse, gymnastics, I'd be curious if it's the same thing in wrestling, if your experience too, but almost back pain's this normalized aspect in terms of everyone gets back pain, or a large majority of athletes get back pain in these sports. And I feel like with that, it's this normalized thing of like, it's part of the playing the sport. And so I think because of that, we're seeing individuals wait substantially longer to actually seek out resources, help, treatment. They wait to a point to where it actually affects their performance, or it gets to a point where they can no longer actually compete. And that's when they come to see us. And at that point, they've probably been pushing through pain through 3 to 6 months. What could have been maybe just a incomplete stress fracture, just a stress reaction in general, no sort of fracture line. Now it's probably has some sort of stress fracture, whether it's incomplete or complete. And now we're drastically drawing out our rehab timeline.
I'll add a little bit to the workload side of things. So I noticed a pretty consistent trend down at IMG when BSIs or spondys in general would come to the clinic. Most of them I feel like would always happen around like late September, early October because the school year started in late August, and most of them would be like first year students at the campus. So I kind of chalk that up as, you're a new student, you're not accustomed to, 20 hours a week in your sport, 3 to 4 lifts a week, you got your speed work, the other 2 days a week. So in many scenarios, their workload had been, doubled, if not tripled compared to what they were doing in high school. And odds are some of these kids might not be doing a ton over the summer, so that workload had likely went from, little to none or very minimal to something super drastic to where there was literally no time for, adequate recovery of soft tissue structures, bony structures, and it just kind of created that perfect storm of such high volume, not nearly enough capacity, not nearly enough, big enough envelope of function to kind of handle that significant amount of stress interspersed throughout a week.
Yeah, I don't think I've ever had a low back, like an athletic low back pain that wasn't in season. Like they're just nowadays, they're always in season. And that's kind of like what you're both are talking about is like, is what we're doing really flaring it up, or is it something outside of here that needs to be kind of talked about with either a coach, a strength coach, something along those lines that we can just kind of like bridge the gap between if it is truly like physical therapy that's bothering it, or if it's like an overall volume issue. Um, but yeah, I think you guys touched on some great points. Do you guys have any wrap up points that we want to talk about? That anything we talked about today? That anything you want think the audience should be aware of regarding this diagnosis, spondies or low back, lumbar like bony stress injuries in general?
I was just gonna say we're pumped to come to R2P in November.
Oh yeah, I'm already signed up.
Love it.
So and then I would honestly, we beat this point across a ton in terms of our low back course, but um, you know, if you have an adolescent athlete who comes in with low back pain, regardless of their sport, lumbar BSI should be creeping towards the top, if not the top of your differential diagnosis list, and probably should think it's a BSI until proven otherwise. Even if you don't get imaging, you're probably still thinking a lumbar BSI until, they get symptoms resolved and are gradually progress back to sport. So yeah, that's probably the thing that we'll leave it off with.
Yeah, and if you get an X-ray and it's negative, that still doesn't mean they don't have a BSI. Like X-rays are gonna miss like 70% of them. So if you're still suspicious, make the clinical push for further imaging.
Perfect. Well, thank you guys very much for your time, and I always learn something when I talk to you guys, so I appreciate it again. And well, I'm sure we'll be in touch.
Thanks,
Yeah,
John.
thanks again, John.
Thank you.